Thank you, everyone. Thank you all for joining us today. It's so great that we have a lot of interest in this critical topic. So my name is Dr. Ninh Tran, and for those of you who have not met me, I'm the Medical Officer of Health for Southwestern Public Health. So that includes Oxford County, Elgin County, and St. Thomas. I'll be joined also with my colleague, Peter Heywood, who's the Director of Healthy Communities, and he is responsible for overseeing a number of different programs, including our work in injury prevention, and that includes injuries that are related to substance use. So in terms of what we're going to be covering today, we're going to start with the local data and describing the opioid crisis in our community, providing an overview of consumption and treatment services, including what they are and what they are not. Provide an overview of the feasibility study that we at Southwestern Public Health did earlier this year, including findings, recommendations, and next steps. We do intend to make this interactive and have a lot of time for discussion and questions. So please, if you've got questions throughout, please put them in the chat. My colleague Natalie is going to be monitoring the chat and then facilitating questions and answers at the end. Slide. So as you're aware, we've got a growing crisis from the use of opioids in our community. And there are many different reasons for this crisis. Next slide. And a big part of it relates to the COVID pandemic. So first of all, the pandemic interrupted lots of different health and social services throughout the 2 years and delayed the start of any new initiatives addressing this issue. People who are experiencing addictions were also isolated and often were forced to use drugs alone, which increases the rate of opioid harms with it. And in the past 2 years, we've also seen a rise and worsening of the unregulated drug supply, and that's gotten worse in terms of toxicity. So we've seen a lot of different harms from opioids that have resulted in the last few years. That includes emergency department visits, hospitalizations, and deaths. So that'll be the focus on the next 3 slides. So the first slide is shown here, and these trends have typically worsened in terms of rates since 2016. And so you can sort of see that since 2016, both in Ontario but also in Southwest Public Health, that our rate of opioid-related emergency department visits have gone up. And particularly starting in 2019 to 2021, where we saw a steep rise, and at the end of 2021 had emergency department visits that were about 1.5 times what the provincial average was. Next slide. Same with the hospitalizations. We've seen been actually worse than the province for over 10 years now. And since 2016, all the way to 2021, we've continually gotten worse in the sense that we're almost double the rate of hospitalizations compared to the province. Next slide. Deaths, and again, 2019, steep rises in our opioid-related deaths, and we've more than doubled our rate of death from 2019 to 2021, and we've surpassed the provincial average on deaths. Next slide. So, I mean, as I've shown in the last 3 slides, we certainly have a local problem. Our numbers are worse than the provincial average now, and we have to start looking at different ways of addressing it. This is just more to show it's new data we haven't presented before, more specific to Woodstock and Woodstock General Hospital. Hospitalizations and admissions have been fairly stable, but you can see this sharp increase in emergency department visits in the Woodstock General Hospital. Next slide. So this slide, and it comes directly from our opioid monitoring dashboard, which is online and publicly available. And what I think it really shows, it dispels one of the misconceptions that people have. People think that our overdoses and our deaths are happening to those on the streets, and they certainly do. But that's not where the majority of the issues happen. If you look at the slide, most of our deaths are happening in those in private dwellings. So these are individuals who have either their own apartments, condos, or houses. Whether they share it with roommates or other family members, and a minority are homeless or live in collective dwellings. And collective dwellings might be things like group homes, boarding houses, that type of thing. But again, it shows that most of our deaths are happening in those with their own place to live, and it could really happen to anyone in our community in terms of to our family members or friends, people who they're all at risk, and that's why it's another reason it's a critical issue that we have to address as a community. Next slide. So how do we address this crisis, and what are some of the options? So we have to take a step back in terms of what is, what's the framework, what are the general approach to addressing substance use, whether it's opioids or alcohol or tobacco. And we generally talk about the 4-pillar approach: prevention, harm reduction, treatment, justice, and community safety. And each of these, we have to do all 4 of these areas and to be really effective. Public health typically works in the prevention and harm reduction part, and we'll talk about CTS, which is one option within harm reduction. But we work with our community partners, such as yourselves, in all 4 categories, and we all have to work together in order to be successful in addressing it. Next slide. So in terms of exploring solutions, we really have to look at, again, the 4 pillars and talk about harm reduction. So harm reduction is an approach that meets people where they are at in terms of their drug addiction. So we work with people, regardless whether they're ready for treatment or they're not ready for treatment, to look at ways to reducing the short-term and long-term harms of it. So this might be providing education. It could be providing sterile supplies, naloxone, stigma reduction. Again, all with the intention of reducing the harms for it. And harm reduction also helps connect people to different services. That might be to treatment services and addiction services, but also a list of wraparound services, including primary care, income support, housing, and other social services, to name a few. So what we've done in our approach is to look at this from a systems point of view, and in terms of harm reduction services, look in terms of what services are available in our community and what services are not available in our community. We looked at what other jurisdictions are doing and some of the evidence and literature out there, and then compare them. And so some of the things from a harm reduction perspective that we haven't implemented in our communities at the time would be things like decriminalization, consumption treatment services, which is what we're talking about today, safe supply, and drug checking. Because we have to do something more than what we're currently doing if we're going to change the trend of worsening emergent visits, hospitalizations, and deaths due to opioids. Next slide. So in terms of consumption and treatment services, I mean, you've probably heard of supervised consumption services or supervised injection sites. So that's like half of the equation. That's the consumption part. And there's also a treatment component to this. So the consumption part is where people are bringing in their own pre-obtained supply, and they are using it in a place that is safer under medical supervision, or there are other people around that can respond to any overdoses. And I do want to reiterate that this isn't a model that provides drugs to individuals. People are bringing their own supplies, and they're using it just in a safer place rather than doing it alone in their own homes or in public settings. And the other part would be the treatment services, and that would be providing direct access or direct referral pathways to treatment for addictions, as well as a whole host of other wraparound services, such as primary care, income, social supports, mental health supports. Because if we can help people, um, tackle on other critical health and social services needs that people have, they will be also more ready to tackle their addictions. And so it's a comprehensive approach to harm reduction. Next slide. So the CTS model is a provincial model of consumption treatment services. It's one that's provincially funded. They fund up to 21 sites. There are clear parameters in place to it. And currently there are 17 sites operating across Ontario. So we would be looking towards doing something similar and learning from the experience from others. And what other CTSs are showing is that although overdoses are happening, they are being responded to immediately because people are there, and we're not really seeing any deaths. The overdoses are being reversed. They're getting quick, treatment and paths to paramedics, and lots of referrals happening to addiction treatment services as well as primary care, income supports, and many communities have dashboards on their CTS and great statistics on what they're able to accomplish across the province. So then I'm going to hand it over to my colleague, Peter Heywood, Director of Healthy Communities, who can talk about the feasibility study that we did earlier this year.
Great. Thanks, Dr. Tran, and welcome everyone. As Dr. Tran alluded to, the quantitative data speaks to the need for additional efforts, and this is where the feasibility study came in. And it investigated the qualitative data from a variety of perspectives, including people with lived experience of substance use, service providers, businesses, municipal leadership, and community members, and to consider what services might be feasible within our geography. Specifically, the feasibility study asked, is there a perceived need for consumption and treatment services? Is there buy-in and support for consumption and treatment services? And finally, are there potential logistical challenges to offering consumption and treatment services locally, such as model types, operations, and practical components? Next slide, please. So we went through the process of collecting data from various groups. We did semi-structured interviews with 30 people with lived experience, and we conducted focus groups with 33 participants representing service providers, business owners, and community organizations. Thirdly, we conducted a community-wide online survey which reached 547 people, and of those, all of which responded. Finally, we also conducted a limited number of interviews with local politicians. The data from this process was analyzed, and the External Advisory Committee, which is an intersectoral group of local service providers, politicians, business representatives, and people with lived experience, provided additional feedback and insights on this data as part of the data event that occurred in April. The findings from the feasibility study were then presented to our Board of Health at the June 22nd Board of Health meeting. Next slide, please. So several key themes emerged from the study. There was a perceived need for consumption and treatment services among people with lived experience, municipal partners, and most community members participating in this study. There was also support for consumption and treatment services locally among all groups participating in this study. There is a preference for the embedded model if the service is made locally, with the option of a mobile model for outreach in rural areas in Elgin and Oxford counties. An embedded model is where the consumption and treatment services is embedded with another setting, such as a hospital or a shelter that people with lived experience typically frequent. There's also support amongst people with lived experience for peer involvement in consumption and treatment services operations in either paid or voluntary roles. They also highlight the importance of wraparound services and supports were identified as a potential need. Specifically, the downtown and central areas of St. Thomas and Woodstock were identified as the best locations to operate consumption treatment services in our region. For the rural communities, including Ingersoll, Elmer, and Tillsonburg, were highlighted as ideal locations for the use of mobile units. We also heard from a number of respondents. The findings noted that they needed for wraparound services and support for any potential consumption treatment services site. Examples of such services and supports include mental health support, detoxification, rehabilitation, wound care, and housing support. We note there have been no formal discussions regarding sites, and these broad locations are collected to help guide future conversations around this topic. To be clear, Southwestern Public Health strongly believes that if further investigations of this intervention are done, additional community consultations around the potential locations will be necessary. Next slide, please. Study participants identified both facilitators and barriers to success. Facilitators identified included engagement in planning and location selection, education on the purpose of the site, reducing stigma and addressing misconceptions, ensuring accessibility at any potential location, and treating clients with dignity and respect. Conversely, barriers included including choosing the right location, the lack of community buy-in, misconceptions of consumption treatment services, and deterrence for potential clients to visit sites. Some of the more common mitigation strategies to address these barriers included using evidence-based education and transparent communication, implementing an evidence-informed planning process, choosing locations that are accessible and that makes both people with lived experience and community members comfortable in inclusive spaces, building trust with potential clients of consumption treatment services, and including peers in roles both on-site and in outreach activities. And finally, ensuring a wide range of needed services are on-site. Next slide, please. So with regards to recommendation number 1, following a data review of the session's finding with the External Advisory Committee, the following recommendations were developed. The first recommendation is that Southwestern Public Health consults with local partners, including but not limited to hospitals, community health centers, community organizations, and the Elgin and Oxford Ontario health teams on the feasibility and application process requirements of such partners who are considering operating consumption treatment services in Southwestern Public Health's region. Recommendation, thank you. The next recommendation was that Southwestern Public Health should support discussions to consider potential locations of facilities offering consumption treatment services that meet the requirements for federal approval and provincial funding. The process shall be done in consultation with people with lived experience, the public, business owners and operators, Indigenous community partners, health system partners, municipalities, and other community partners. The third recommendation is dependent on the outcome of the consultation process outlined in recommendation number 2. Based on that outcome, Southwestern Public Health supports obtaining letters of support from respective municipalities, for example, the City of Woodstock, the City of St. Thomas, based on the community's readiness to participate and the participation of willing community partners capable of operating a potential site. The letters from the municipalities are required for applications to provincially funded consumption and treatment sites, but are not required for sites that are not provincially funded. And really, community readiness is defined as how, refers to how the community is prepared to take action to address a particular health issue. To address concerns raised during the consultation process, further education, consultation, and data collection efforts will be required with the general community, business owners and operators, Indigenous community partners, municipalities, and other community partners. Education efforts will include information on the purpose and the expected impacts of consumption treatment services as informed by the experience of consumption treatment services in other areas of Ontario. In addition to these efforts, it's also recommended that consultation should be developed and delivered with people who use substances and community partners who support and or interact with people who use substances. To address concerns raised during the consultation process, further engagement around data collection efforts will be required with the general community, business owner operators, and other community partners. They'll focus on the expected impacts of consumption treatment services. In addition, it'll also include recommended consultation that will be developed with people who deliver, people who use substances, and community partners who support or interact with people who use substances. And now I'll hand it over to Dr. Tran to talk about the current status.
So thank you, Peter. So as we had a meeting on June 22nd with our Board of Health to review the findings of the report and recommendations, and they were unanimously approved by our board. And we got approval to move forward with phase 2. And phase 2 is quite broad. It's still a long journey ahead of us that we would look at further consultation, whether that includes providing education sessions or information sessions such as this, consultation, asking for feedback, and other data collection, just in terms of understanding where the community is at and further addressing any of the needs or questions or concerns that people might have. And this would include engaging our broader community and general public, business owners, politicians, municipal partners, Indigenous community partners, as well as community partners and municipalities. We certainly want to also be very engaged with those experiencing addictions with lived experience, because we have to design a service that works for our clients and needs. So again, this is just part of phase 2. That a lot of discussion is to happen. No decisions have been made, and this is our information session here is part of the discussion on this topic. So next steps, where do we go collectively from here? And so first of all, if people want to learn more about CTS, a refresher. I know we're all coming from different backgrounds and might have different starting amount of information. As one of the, we created a central resource and webpage on it, www.swpublichealth.ca/CTS. And it will also provide you a link to the actual study itself, so where you can read the study for yourself and find the detailed results of the study, as well as other background information. As Peter mentioned, there is a Woodstock public meeting on September 26th. So any of you can choose to make a public delegation and speak to this topic at the meeting. So the deadline for request is a few days before, is the week before. So on noon, September 22nd, you would contact Woodstock and ask to speak on it, and you speak on it from your own perspective. You can also attend the September 26th meeting either in person or you can stream it online on the YouTube channel. And finally, throughout this process, whether it's, we're not talking about just like one opportunity today or on the 26th, our doors and channels are open. You can talk to us about questions you have about this issue, any concerns you might have, or an interest to participate, including operating the site itself or being a partner that provides any of the wraparound services, and you would talk to Peter about that. So here's an opportunity for a discussion. Please feel free to ask any questions you might have or provide any comments that you feel that should be heard.
Thank you, Peter and Dr. Tran. We will now open it up to questions. Please raise your hand in MS Teams and identify any organization or interest that you may represent today when asking your question. We have a question from Emily Porchak.
Hello, thank you for this presentation. I am attending on behalf of the Oxford, Ontario Health team. I have one question. You mentioned there being 17 provincial sites that already have CTS. Is there a list of those sites on that link that was shared with the information about CTS, or is there a way to find out which sites are already operating in Ontario to look more into those?
Yes, so thanks for the question, Emily. I can There is a web page the province has that outline the different sites. And if you give me a minute or two, I can see if I can find it during this chat and put it in, or if not, we can circulate it out.
We've also had a link included in there in the chat from Jillian Dresen. Thank you, Jillian. Any additional questions for today? I don't see any hands raised, so that concludes our time for today. Thank you for your participation in this ongoing dialogue. Please reach out to Peter Heywood with additional questions, or if you have interest in being an operator. You'll find his contact information in the chat. Thank you, everyone, and have a good day.